evening, everyone. My name is Dr. Banmeet Ahluwalia. I serve as the Chief of Medical Oncology, Chief Scientific Officer, and Deputy Director of the Miami Cancer Institute. And I could not be more thrilled today evening to spend this evening with you, but particularly because I'm sharing the podium with Dr. Tim Cloughesy, who is the Distinguished Professor in Neurology and the Director of the Neuro-Oncology Program at UCLA, but more importantly, one of the key thought leaders in the field and has been a dominant force for mentoring several of us, including myself. And what we are really excited about is to share some exhilarating data of really a success story of precision oncology in brain tumors finally. Because we deserved one. As a medical oncologist, I was always envious of my friends in lung cancer, breast cancer, having targeted therapies for their patients. And now we have, for our patients in brain tumors, hopefully beginning of several success stories that we can build for our patients, because ultimately it's all about our patients. So today's we are looking at glioma care, and we're going to be applying the latest evidence on molecular targeted therapies in IDH mutant gliomas. So welcome again, Dr. Cloughesy and I would love to welcome you to this program. We would like to start off by thanking PeerView and the American Brain Tumor Association for providing for this session, and Servier Pharmaceuticals for providing the educational grant which helped put this symposium together. Please, very important, we love to have engaged audience, so thank you all for sharing this evening with us. Look out for additional polling during the presentation. Submit your questions, and we will answer them through the Q&A section in the end. In the room, learners, please use your personal device to scan the QR code, which is on your desk, on the following slide as well, to respond to polls, and feel free to ask us questions. For the virtual listeners who are going to join us virtually, please respond to the polls on your screen and enter the question in the chat window. This is the QR code, obviously, and the more engaged you are, the more chances are for you to win the $50 gift card. Thanks to PeerView for providing the gift cards. And the way you do it or increase your chances of winning are by completing the pre-event survey, answering polling questions, and submitting questions to us faculty. And for the slides and this educational material, please feel free to visit the perview.com/2025 glioma. And obviously, you can scan the QR code as well. What are the goals for today? This evening, we hope to enhance your understanding of the latest evidence and practice guidelines supporting the use of molecular testing, which we think is the key in brain tumors, to help targeted therapies in patients with IDH mutant gliomas. Equip you with strategies to develop customized treatment plans for patients with IDH mutant gliomas that will help you consider clinical trial updates, molecular testing results, and guideline recommendations, and provide guidance on addressing the nuances of treatment with IDH targeted therapies, including adherence, adverse event management, appropriate dosing and modifications, and also patient counseling. We would like to thank American Brain Tumor Association, which is an excellent resource and partner for patients with brain tumors and their caregivers. ABTA's mission is to advance the understanding and treatment of brain tumors with the goal of improving, extending, and ultimately saving the lives of those impacted by brain tumor diagnosis. And I can just tell you, in the last 2 decades of work with them, they are an amazing organization, very patient-driven, and they've funded research to drive further advancements in the field of brain tumor. And like I said, it's all about the patients. We all are here today so that we can help improve the lives and quality of life and help our patients live a longer life and more meaningful. So we'll start that with Kevin sharing his life journey after his diagnosis of glioma.
Well, welcome, Kevin. I'd love to start off by having you introduce yourself and share about the type of brain tumor you have.
Yeah, thank you for having me. My name's Kevin Wilkinson, and I unfortunately have an oligodendron glioma that we found back in 2019.
So what was it like when you received that diagnosis, if you can take yourself back to that moment?
What they don't tell you is your world gets completely put into 5th gear and then flipped upside down. You're trying to find the right doctor, you're trying to find the right area. You don't even really know what you have yet because it's not like they could just go in there and take a peek and then come back out. So no one's there to take you through the process or what's happening next. And luckily I had a bunch of good resources that I was able to reach out to. You know, you go through this questioning, what am I going to do next? And am I going to live? Am I going to die? Or, you know, you have all these unanswered questions. And I've got to say, the medical field, once I got up into the area, was just spectacular.
Thank you so much, Kevin, for sharing your story, and which is very typical of what our patients go through. So, as I had talked about, we are living in the era of precision medicine and precision oncology. And this was demonstrated in the WHO 2021 guidelines for classification of brain tumors, which totally changed how we looked at tumors. So if we look at adult diffuse type gliomas, molecular profiling really became the foundation for classifying our patients. And we look at the disease, whether it's IDH mutant or IDH wild type. Those who have IDH mutant gliomas then are further characterized as those who have IDH 1p19q co-deletion, and typically tend to be called oligodendrogliomas, if you remember, with grades 2 and 3. And those who have astrocytoma, that means that they do not have the 1p19q co-deletion, but their IDH mutant can be categorized as 2, 3, and 4. And the 4 was the new category. Previously, we used to have a category of IDH glioblastoma that was IDH mutant, and we don't have that category anymore. And then obviously we do have glioblastoma, which is IDH wild type, the most common glioma we see. And then we also have diffuse midline gliomas, and a prototype of that is H3K27, and we actually have therapies for that. So exciting stories for our patients. In terms of how common are these tumors, almost 12% of all glioma diagnosis are those who have IDH mutants, and we do know that patients who have IDH mutant gliomas tend to be most common in people who get diagnosed in their third and fourth decade, and we know that there is a greater propensity in men, 1.3 versus every one female. And here you can see different graphs, and obviously those who have oligodendrogliomas, they have IDH mutant in all of them. But there are, as we knew until a few years back, there were several challenges in IDH mutant glioma care, just like all brain tumors. For long-term survival, when we looked at SEER data, overall survival had not changed, unfortunately, significantly for decades, highlighting need for new, novel, personalized strategies based on molecular profiling of our patients. Chemotherapy until recently, and I'll show you some data around that, was the predominant treatment option beyond, in addition to radiation for patients with gliomas, despite several patients having molecular characteristics. So molecular testing is, as I said, is a foundation. And until recently, some of the data showed that a lot of patients were actually tested in like third recurrence of tumor, and where targetable mutations, including IDH mutations, especially in patients with low-grade gliomas, was present in more than 2/3 of those patients, meaning that we could do better for our patients. And there were persistent gaps in quality of life, which is a significant problem for our patients. Obviously, as Kevin shared, right, the world of our patients gets upside down when they get diagnosed, because not only they have a brain tumor, but because of the brain tumors, there's significant challenges for them. And there are a lot of clinical variables depending on how large the tumor is, which can impact or have patients with a worse quality of life. And then treatment, obviously, the treatments we give people has an impact. We all know chemotherapies are toxic because they do not select between those cells that, the cancer cells versus the rest of the body. There's a high degree of symptom burden, and a big challenge for our patients, especially with gliomas or IDH mutant gliomas, is the considerable epilepsy burden. And Dr. Cloughesy will share with you some really invigorating data and how we are even helping our patients' quality of life by helping with their seizure control with some of these new targeted agents like vorasidenib. As patients suffer neurocognitive deficits and things like that. So this was the 9802 RTOG study led by Jan Buckner, which really showcased that radiation and chemotherapy, which was procarbazine, lomustine, and vincristine, was better than radiation. and both in terms of progression-free survival and overall survival. But also what is more important in the curve on the right side, as you can see, the bulk of this benefit was actually driven by those patients who had the IDH1 alteration. In fact, there was no difference in those patients who had IDH wild type. And there was a considerable benefit, though, of chemo and radiation for these patients compared to radiation alone. There was then work done by Erica Bell from Ohio State, where she looked at retrospectively in this database and then found that the patients who had a co-deletion of 1p19q along with IDH alteration, they were the patients who did best for both progression-free survival and overall survival. And obviously, we know IDH alteration actually just has been a beautiful story since the initial paper in 2008, which basically found, and for the fellows and residents in the room, when you were in medical school, you learned the Krebs cycle, and what we know is that isocitrate then gets converted to alpha-glutarate. In those patients who actually have IDH mutations, this gets converted into 2-hydroxyglutarate, which basically is an early and an important transformational event that leads to a number of genetic and epigenetic dysregulation in these cells and basically gives them immortality and leads to carcinogenesis. This was a very nice paper showcasing the concordance of presence of IDH alterations in tissue, but also in plasma. But here you can clearly see the patients who have IDH alterations have better survival. It is a prognostic factor, we know that, but now it's also predictive, and we have drugs that can help us help our patients live longer. This is a case. It's a 40-year-old patient who presents with residual grade 2 glioma as confirmed with MRI. Molecular testing was not conducted at baseline, which was the case for a lot of our patients. Now, based on the information that you received, what treatment option would you consider? Would you recommend other baseline testing prior to treatment selection? And please use this QR code to submit your polling. Now we'll have Kevin sharing his journey.
So, had a craniotomy, and then the tumor extraction, and then that went really well. You know, it was a much more complex tumor than they thought. On the imaging, it looked like it was very encapsulated, but on the backside, it had some fingers that went deeper in, and I know they did their best and tried to get everything, and yeah, it was unfortunately didn't get 100% of it, and that's kind of why I'm here today.
Yeah, and of course I know that you participated in the vorasidenib trial. So how did you learn about that?
It wasn't until much later, God, if I had to think, maybe a year and a half after my surgery, I was still in the trial time frame, and I got a call from Dr. Taylor, my neuro-oncologist, and she says, hey, I don't know if you've heard of this trial, and it just happened to be the same trial and all of my parameters fit. I don't want to dismiss anybody else's struggle, but for me, it has been extremely easy. My reaction to the pill has been very limited, but for me, really just having that energy loss at certain months. The next month, I'm right back at it. And then it kind of dips down a little bit, and then it gets back, and I know there's probably some external factors that play into that. And then kind of for me, a little gut health issue, but if I stay on top of it and I eat the right things and, you know, I really stay strong with that, and it's nothing that's life-changing. It's just eating the right things and doing all that. That was very easy for me. And then, yeah, so the overall effect of this vorasidenib has been very minimal for me. It's been great. It hasn't affected my ability to be a dad, or a husband, or, you know, run my company. So it's been very nice.
And so what happened when the trial ended? Are you still taking vorasidenib?
Yeah, fortunately, I'm one of the OGs. So I think I'm on my 56th cycle or something. So it's been almost 4 years. And so they did come to me and just said, "Hey, you're one of the old guys. So do you mind staying on it?" And absolutely, I'm gonna stay on it. It just goes back to really giving back, and if they can learn anything from me that's going to help the next round or tomorrow's diagnosis of what I have, put me on board. Things are great. The tumor has shrunk in overall size and density, and it's just been spectacular.
And now it's my pleasure to introduce Dr. Tim Cloughesy, who's going to enlighten us about navigating the gray area in glioma management.
Thanks so much, Mandeep. So the standard of care in the past, before IDH inhibitors came out, for grade 2 gliomas, whether it was oligodendroglioma or astrocytoma, was whether we would do watchful waiting, usually with a gross total resection or near total resection, or radiation and chemotherapy. And based on the data that Manmeet shared, we saw the benefit of adding chemotherapy to radiation. Since these data and the vorasidenib has been approved, the NCCN has come out with a different set of guidelines. And just as a reminder, the different categories of evidence that they use, as well as the preferred interventions or the preference that they set ahead of time. Category 1 is basically a phase 3 study, the best possible evidence that we have. Category 2 is a lower level of evidence, but the majority of the NCCN members have consensus, over 85%. The category 2B would be that, again, also lower level of evidence, but that the consensus is within 50 to 85%. That gives it 2B. And category 3 is really a setting where there's significant disagreement between the group. We have preferred intervention, we have other recommended intervention, and then we have useful in certain circumstances. So this kind of outlines what it was around the time that it was approved in 2024 on the right-hand side. And then in the middle there, we have the most recent 2025. And the indication includes having no residual disease. So you could see that the vorasidenib, ivosidenib have bumped up to a 2A in that setting with residual recurrent disease. So as we have here, for those patients who are not thought to require radiation and chemotherapy, you could see that vorasidenib has been bumped up and stayed at 1. It was at a 2A before, but now at 1. And ivosidenib at 2A, observation 2A, clinical trial 2A. And then those who go on, who should, the thought is they should receive radiation, of course, clinical trial, and then radiation chemotherapy. In those settings where we have a lower Karnofsky performance status, again, the option comes up that both radiation chemotherapy, temozolomide alone, vorasidenib, ivosidenib are all considerations, as well as clinical trials and palliative care. When the original studies were done, we were evaluating ivosidenib and vorasidenib, and it took on all comers. These patients had a variety of grades. They had non-enhancing tumor, enhancing tumor. And the cleanest way to separate these out for differences was to separate them into enhancing and non-enhancing. We see here with ivosidenib and vorasidenib, and you have prolonged progression-free survival in both settings in the non-enhancing setting compared to the enhancing setting. But that's kind of a prognostic feature when you have contrast enhancement present. So it's not unusual to think that there would be prolonged progression-free survival just because we're in the non-enhancing population, and this is a single-arm evaluation in phase 1. So having some additional evidence of effect was very helpful, and being able to show that for both ivosidenib and vorasidenib, in the non-enhancing populations, we saw more tumor shrinkage that was present, and relatively less so in the enhancing setting. So we have these two drugs. They both showed the capability of shrinking tumor. The thought was, how do we decide how to go forward? And that's where this window of opportunity study went forward, looking at patients who had the R132 variant of IDH mutation. They were randomized to 2 doses of vorasidenib at 50 and 10, 2 schedules of ivosidenib at 500 a day versus 250 BID, and an untreated population. These patients had non-enhancing tumor, could have been grade 2 or grade 3. They were eligible for a resection. They received drug for a month and then had that surgery. And that's where a number of pharmacodynamic evaluations as well as pharmacokinetic evaluations took place to help and try to understand which of these should be selected to go forward. The patients had continued follow-up afterwards, and I'll get that a little bit later. One of the important things was the brain-to-plasma ratio. We knew that vorasidenib had a favorable brain-to-plasma ratio. It was 1.7 roughly, whereas ivosidenib was about 10%. However, the exposures with ivosidenib was much greater than that of vorasidenib. So in the end, the actual amount of drug that got in was very similar between the two, given the potencies of each of these therapies. So that alone probably wasn't a differentiator. This next slide was more of a differentiator, and that is the 2-hydroxyglutarate that was being measured. We had the 50 milligram of vorasidenib, 10 milligram of vorasidenib, and then the 2 doses of ivosidenib. You could see there's significant variability with ivosidenib, and maybe that has to do with the relative blood-brain barrier penetration that, or leakage that may be present in a low grade, but more consistent, less variable in the vorasidenib setting. And that's, of course, compared to these internal and external controls. There were other findings. We all think that 2-hydroxyglutarate has an immune suppressive effect. And with the gene expression analysis, we saw that in the setting of decreasing the 2-hydroxyglutarate greater, there was an increase of interferon alpha as well as interferon gamma, and that there was increased T-cell infiltration, both with CD3 and CD8. So before we move on, please take a moment for this poll about the mechanism of IDH inhibitors. Okay, we're going to continue to put your information in, but we'll continue. So these data really helped us understand that maybe vorasidenib would be the better selection here. One, it's IDH1 and IDH2 with inhibition, better brain penetration, less variable with regard to the 2-hydroxyglutarate. So Indigo trial was started, and these were the key eligibility criteria: greater than 12 years of age, IDH1 or 2 oligo or astro. They had to have had prior surgery only, no other therapies. There had to be residual tumor at some point in time between a year after the surgery and 5 years after the surgery. And you'll see this is because the primary endpoint was progression-free survival, and we wanted something to be measurable that we could that we could look at from the beginning to understand the treatment effect, and that there was no need for immediate chemotherapy or radiation therapy as per the investigator. Patients were stratified on 1p19q status as well as baseline tumor size. And as I said, the primary endpoint was progression-free survival. It was a blinded independent review. Secondary endpoint, time to next intervention. This is a placebo-controlled, double-blinded setting, the best kind of trial that one could run. The MRIs are evaluated every 3 months. There were 3 pre-specified analyses that were going on. The first one was a futility analysis after 55 progression events. The second was at 123 progression events. That happened in September of 2022. That was found to have statistical significance, meeting all the criteria for success, and the study was stopped. Information was then gathered over that time and cleaned up until March of 2023. So the data I'm going to show now more has to do with the 2023 timeframe. The patient characteristics are really evenly matched here. Equal oligodendroglioma with astrocytoma, which is nice. Interesting, although we thought we picked the right baseline tumor size, for stratification. It turns out that really a minority of the patients had a diameter of less than 2 centimeters. And then these are the results. The progression-free time in the vorasidenib arm was not reached. In the placebo arm, it was 11.4 months. The hazard ratio was 3.5. That's not something we tend to see. When we've seen hazard ratios that we've responded to and had analysis of, they're closer to 0.6, 0.65. The time to next intervention was also significantly different here. You see a hazard ratio of 0.25. I always say there's a little bit of concern about the patients who were in the placebo arm. They came on the study to get vorasidenib. They had the ability to cross over. Many of them crossed over earlier than maybe some of the patients would who had progressed on the vorasidenib setting. Nevertheless, there's still a significant number of patients who were still being treated in the vorasidenib arm. Progression-free survival means that there's no growth up to 25%. So this is why measuring the tumor growth rates were really important so that we could understand that tumors were shrinking. We saw that there was tumor shrinking in the phase 1 study. It was, maybe 4 patients that we were absolutely clear that it was shrinking. Here we have unequivocal evidence that 1, there's a difference between the placebo arm and the treatment arm, and 2, that this shrinkage occurs slowly over time, but it is continuous and it is cumulative. I told you before that in the perioperative study that there was longer-term follow-up. And those patients all went on to have surgery and then they had follow-up. Well, down here, this is the group of patients that had only prior surgery, did not have prior radiation that was mixed in with the totality of the group. And we have these data which maybe gives us an insight what we're going to see with regard to progression-free survival. It's 55 months in the vorasidenib arm, 68 in the ivosidenib. These are not statistically different. They're not set to kind of look for a difference between the two, but they give us some insight into what we may be seeing about the durability of progression-free survival. These are the forest plots. This just helps us understand with all the different subtypes that exist, is there anything showing us that it is not really performing as it should be? All of these are showing similar effect sizes. It is interesting that those that are over 40 had a better effect size than those that were under. Again, not statistically different. But also a slight improvement, I would say, in the oligodendroglial versus the astrocytic groups as well. No other differences really exist here. Shrinking tumor slowly over time and having a better progression-free time is good. I think we all understand that, but having some other functional benefit would even be better. The patients who came onto the study could not have had active seizures coming onto the study. Nevertheless, while on the study, 54 patients had seizures with vorasidenib and 56 with placebo. But the number of seizures that we saw in the vorasidenib arm was dramatically different than that in the placebo arm. And the rate on treatment seizures per year is 18 for the vorasidenib of this population and 51 in the placebo. This was statistically different. This is a secondary analysis, not a primary analysis. Also, I think what was interesting, and this more has to do with this population, what's the risk of putting patients through watchful waiting or having them on vorasidenib with regard to health-related quality of life? And the same thing is occurring here with cognitive evaluation, so our neurocognitive tests. There are no changes throughout this time for the placebo arm and the treatment arm, and even at the time of progression, there was not a difference in the health-related quality of life or neurocognitive effect, pointing to the fact that this is a time frame where we can utilize therapies like vorasidenib here without harming the patient and putting them at a disadvantage before they would move on with radiation and chemotherapy if they progress. There are some liabilities that exist with vorasidenib. I think we heard from Kevin that it's very well tolerated. They feel fine. The patients in general feel fine. These are the grade 3 or greater adverse events. There is a liver function test liability here, mostly with the ALT versus AST. You could see that the grade 3 get up to around 10%. Those that had treatment interruptions, and really you have to compare placebo to vorasidenib and almost take the difference between those to understand what's the vorasidenib effect. About 9% with treatment, or 7 to 9% with treatment interruption. Dose reductions around 7 to 8% there, and then discontinuation at around 3.6% for the vorasidenib arm. All of these were reversible. There were no fatal AEs that occurred in patients. I'm not going to go through the details of this management of the toxicities and how one adjusts the medications, just to say that it is important to monitor these patients. We tend to do it every two weeks for the first 2 months and then monthly after that. There's a tendency for these changes to occur relatively early on, but they still can occur later on after several months. So it's important to continue to evaluate the patients and then follow the guidelines for altering the dose of vorasidenib. So go ahead and take this other polling question. This has to do with a follow-up poll on recent clinical trials. So the FDA approval came in August of 2024. It had the following description: approved vorasidenib for adult and pediatric patients aged 12 years and older with grade 2 astrocytoma or oligodendroglioma with a susceptible IDH1 or IDH2 mutation following surgery, including biopsy, subtotal resection, and gross total resection. Note that the FDA approval and the indication goes beyond what is the inclusion-exclusion criteria for Indigo, in particular having to do with the gross total resection. This is the first approval by the FDA of a systemic therapy for patients in this setting. So who should use vorasidenib? This is something that I think is an evolving process. We don't have the absolute answers to all this, but we're beginning to understand it, and of course we take the information from Indigo and try to apply it to whatever it is that we could move forward with in the care of our patients. So is it limited to the care to the Indigo eligibility criteria as we have here that I already discussed? Is there an opportunity where, and how soon should it be started? We have surgery. Should we be immediately starting? The Indigo trial waited at least a year, again, because there had to be a valuable tumor before going forward. But I know in our practice many times, and tell me, Manmeet, if this is something that you see, we usually get a scan 3 months after surgery, let all the information come in. If it's grade 2, we're not necessarily in a hurry, but then that's usually the time when we think about starting it. And the discussions could take place earlier before deciding with the patient if they'd like to initiate that therapy. But I'm not sure, I'm just curious if you have a different experience.
No, actually, if you look at the FDA label, right? So the label doesn't say you have to wait for a year.
Right.
And so, now we have a therapy, and obviously we know the kinetics, right, of what it does to a tumor. And one of the things is obviously, seizures, as you really clearly articulated. So if there is something additional that we see or we feel that this is something that will benefit the patient, then we don't really need to wait for a year. But I agree with you, we love to get that baseline scan 3 months later where all this post-surgical changes kind of settle, so that we can follow this patient better. But we have several patients who actually want to start sooner rather than later because patients know they have a brain tumor. And as was explained by Kevin, we all know, even when we have a few neurosurgeons in the room, despite the best efforts of our neurosurgeons, there's always some residual disease.
Right.
So it's just a question of, what are the other symptoms which are happening with the patients, and if someone's having seizures, it's even more of a reason to have this discussed earlier.
Right, thanks. And the same thing, gross total resection was not in the Indigo trial, but however, it's in the label. Some people have tried to differentiate between supratotal resection and just a gross total resection, like margins very close. Others have talked about the relative value of doing it in oligodendroglioma versus astrocytoma in the setting of a large resection with significant margins. I think that there's been debate about this. We don't know the answer, but I think my bias is to go more astrocytoma for sure. Good resection of an oligodendroglioma and a supratotal resection of an oligodendroglioma I might sit on a little bit and share that discussion with the patients. Again, the patients many times know, if educated properly, they make great decisions. Should it be used for enhancing tumors? I showed you the phase 1 data. Those phase 1 data are not exhaustive evaluation. I think there's concern that the contrast enhancing tumors maybe have more of the kind of CDKN2AB loss. Maybe that loss of cell cycle regulation is an indication that it's not so dependent upon 2-hydroxyglutarate. But I think it's something that has not been completely answered. And so I'm going to ask you, I'm sorry, but it's hard, grade 2 to grade 3, because many times it's like a 2.5. It's like, on the more relatively benign or non-malignant side of 3, something like that. Do you make any distinction between these in any way?
Again, we know that, if you really look at the oligo data, the 2 and 3s track very closely, though. And obviously, you showed data, previously. I'm actually going to show some data later on,
Great.
which is some real-world evidence of there is a benefit beyond what we have seen.
Excellent.
So which will add, but it's also a situation, right? We have a label, but we in neuro-oncology have had used off-label drugs
Right.
all the time.
Right.
And I think the most important thing, as you articulated, is an informed discussion with the patient and putting the patient in perspective. And the other advantage which we have is we've got multidisciplinary tumor boards in our group, and we typically take these challenging cases there
Right.
and get the input of our radiation oncologists and neurosurgeons, and we put our years of practice experience together and, making these tailor-made decisions. But yeah, definitely, some of it is science, but some of it is also art.
So we have to move forward a little bit here, but I think it would be a nice opportunity during the discussion to talk about what's high risk, where radiation is preferred. This is another case, same case actually as the one that Dr. Ahluwalia presented. 40-year-old presents with residual grade 2 glioma as confirmed with MRI, molecular testing not conducted at baseline, but the molecular testing revealed IDH mutant grade 2, non-1p19q co-deleted, and the care team was evaluating what to do for the patient. I think we'll hold off on some of this, but I think we've outlined the issues around maybe who should be considered for an IDH inhibitor, and the focus on the ability to maintain quality of life in addition to decrease seizures in that setting. So if you guys go ahead, let's do one more poll. All right. Now let's get back. We have another video with Kevin.
Kevin, what resources have you found helpful from advocacy groups like the American Brain Tumor Association or others that you may have participated in?
So all of resources that I was able to approach and be involved with was through my local hospital, because I already had a relationship with them. They already knew who I was. I didn't have to re-explain my personal perspectives on things, and that made it very, very easy and comfortable for me. And having that conduit to get in touch with these people, sit down and have a real conversation, and answer some of the questions that are maybe just more on a general medical field than specific to your type of glioma, your type of brain cancer. Those are very, very important. And for me, it was just I think just more so to quench my anxiety, and I shouldn't say my anxiety, also my wife's anxiety or my family's anxiety, because having that ability to call and get that answer from someone that you trust is extremely important. And you're in a long-term relationship with these people, and that's what people forget. Like my oncologist, it's been 4 or 5 years, and it's just infectious disease and all that stuff. It's just you're in a long-term life relationship with most of these people, and I think the more and more you could broaden out that net and find your comfort either locally or out of town, it's extremely important.
This is just a summary of what we discussed. I don't think we're going to go to any more detail with this here. We'll just go ahead now with Amit to finish us off.
Thank you so much, Tim, for a very comprehensive but a beautiful mechanistic story of really what led to development of this therapy and a great option for our patients. And now in the next 10 minutes or so, I'm going to discuss some of the future directions and ongoing trials for the IDH-targeted therapies in patients with gliomas. And this is a very busy slide, but I just want you to have a take-home message here. And this is obviously the wealth of data that we have seen accumulate. And Dr. Cloughesy went over several of these in great details between the trials that involved ivosidenib, which was an IDH1 inhibitor, but then obviously vorasidenib, where we've seen much more activity, and which is a dual inhibitor, as he explained, both 1 and 2, predominantly designed to cross the blood-brain barrier to help our patients. But there's also developing molecules, and I will talk about them, the DS1001, ultasidenib, Bayer molecule, which actually have shown preliminary efficacy in these tumors, and just a remarkable how much activity we are seeing in this field, but more importantly, opportunities for our patients to help them. And then obviously some of the other questions, as Tim had alluded to, have come up. Obviously, where else could some of the clinical trials with vorasidenib be considered? Because obviously this is FDA approved, but there are still a lot of gaps. We have a number of patients with IDH mutant gliomas, and obviously a big one, as he outlined, is the grade 3 astrocytomas. And obviously we know there that radiation and chemo is the frontline treatment for those patients. And there's an alliance trial with vorasidenib, and this is the schema. And basically, again, we are looking at patients using age as a stratification, which we've had for patients with either low-grade or grade 3 gliomas, looking at, again, the residual disease, which, as Dr. Cloughesy alluded to, was in the VORA trial in grade 2, and then basically looking at is there value of addition of vorasidenib to temozolomide, which, again, has become the most important or most commonly used chemotherapy when we use an alkylating agents to treat these patients. Obviously, there is an update. It's a lot of interest in what's the combination of vorasidenib with temozolomide, which will be used in that trial. And there is, I'll give you the key takeaways, but please feel free to go to the presentation this Saturday from 11:45 to 1:05 session. And essentially, no dose-limiting toxicities were reported. And based on the safety review evaluation, vorasidenib 40 milligrams once daily, which is the dose that we use, and with the standard of care dose of temozolomide was confirmed, which again was not a surprise because we know myelosuppression is the biggest problem with temozolomide, and as Tim had alluded to, transaminases is really the challenge that we've seen with vorasidenib. Then obviously a number of unmet questions or questions that need to be answered, and I will take next 5 to 7 minutes to really look at what are some of the trials. But just to give you an idea, it's so good or so exhilarating to see a busy slide of number of molecules in development for a disease for our patients, because this is really the precision oncology 101. Identifying on molecular profiling, does a patient have an alteration that drives a tumor, and then finding the best drug to treat our patients. And we talked about ivosidenib, vorasidenib, and I'm going to talk more about ultasidenib and DS101 in greater detail. But these are now, again, both compounds which are IDH1 inhibitor. Vorasidenib has a distinction. It's both IDH1 and 2, but these are all blood-brain barrier penetrant, and appropriately designed for patients with brain tumors. And so this is the olutasidenib data, again, phase 1b/2 trial, evaluating this drug in patients with recurrent or refractory IDH1 mutant gliomas. And here you can see response rates. So it was 25 patients were treated, and you can see in the waterfall curve graphs, basically, if you can see those oranges, those are basically patients who are having partial responses, and it's always nice to see responses in your patients. And 2 of the 25 patients responded, and similarly, we saw volumetric decrease in the size of the tumor. This is a slide from Macarena Del Fuente, basically showcasing a patient that she treated, and this is the tumor at the baseline, and you can clearly see shrinkage at cycle 20. Kevin showed his beautiful story, 56 cycles. That's like music to our ears, and because Tim and I, when we used to treat patients with chemotherapy A, we could only give them limited chemotherapy. But if you have patients who are going on 4 or 5 years, that's really dramatic benefit in lives of our patients. Obviously, our pediatric colleagues always do an amazing job with their patients. So this is an umbrella trial with a number of therapeutics based on alterations. They do molecular profiling, which is genomically guided, and umbrella phase 2 clinical trial. And here you can see those patients with IDH alterations are going to get radiation and olutasidenib. There is another compound, the DS1001, which is again an IDH1 inhibitor, which is blood-brain barrier penetrant. And here were 47 patients that were treated in this trial. And you can see 2 of the patients had complete responses out of 35, and 4 patients had partial responses. There were some responses seen in those patients with enhancing components. So what we are finding out is as we'll treat more and more patients, we might actually see some patients with enhancing component who can get benefit. But as you alluded to, we don't know when these patients have enhancing component, do they have more of the CDK2 as you said, alteration, which kind of gives the disease a more aggressive nature, and maybe there we can use combinations of IDH1 inhibitors along with the CDK2, 4, 6 inhibitors as well. And I'll talk about some of those drugs in trial. And obviously, we have now a fair amount of off-label ivosidenib use, and this was a presentation and then a paper put together by Katie Peters and her group from Duke, and basically they had 30 patients who were, and as you can see, very varied ages between 21 to 74 who were treated, and they did show that 12 patients had stable disease, 5 minor responses, 3 partial responses, and 2 patients had progressive disease. So they did have some patients who had partial responses, which is kind of nice. And obviously, there were some stable diseases in those patients who had enhancing disease. So we may not be causing shrinkages in those patients, but we are really helping them with stable disease. And that combined with, if you can get a seizure control, that can have a significant impact on the quality of life of patients. Then more data on ivosidenib, on volumetric growth, because we always like to see kinetics. I know Tim is a big proponent of kinetics in brain tumor, because sometimes we may not hit the criteria of response rates, which was basically designed more for chemotherapeutic agents and more relevant to oncology, and sometimes not as relevant to neuro-oncology. We always like to look at, are we changing volumetric kinetic changes in tumors? Like if the tumor is growing and we can show some degree of shrinkage, that is meaningful for our patients. And clearly this study showed that ivosidenib was not only well tolerated, but it did induce a very nice volumetric decrease in number of patients. Obviously, Michael Platten and his group has been doing some truly groundbreaking work looking at a vaccine targeting IDH1, and here you can clearly look at a trial that they are pushing forward in Germany. And then there is, as Tim had alluded to, really we know 2-hydroxyglutarate is actually immunosuppressive, and there was a beautiful Nature paper that you alluded to, that if you use VORA, you can actually decrease the immunosuppression because you saw an increase in the gamma alpha and gamma interferon, and then you also see the increase in T cells. And so this trial is building on this further, and it's basically a surgical study looking at vorasidenib now, along with pembrolizumab, which is an anti-PD-1 monoclonal antibody, to see if we can even have a better benefit in combination for these patients. And here we are looking at grade 3 patients too, because maybe IDH inhibitor by itself is good, but can we make it better by combining? And this is a randomized trial, which is really going to look at mechanistically what's the benefit of addition of Pembro to Vora compared it to Vora versus just a control to see can we look at window of opportunity studies to look at what we are doing to the PD of this tumor and then looking at the clinical benefit. Again, a very busy slide, but obviously you'll get the slides in your packet if you use the resources. But really a lot of activity basically showcasing that we have a number of treatment options for our patients. There is a lot of interest in demethylating agents. We know that from our leukemia colleagues who have treated IDH-altered tumors. There's a lot of interest in PARP inhibitors. Actually, when we have patients who have IDH alterations, they almost like have a BRCA-ness to them, as Ranjit Bindra will describe it, and then you can use PARP inhibitors for that. And as Tim was alluding, there is a lot of CDKN2 alteration in these patients. So the question is, can we look at CDK4/6 inhibitors? And there are a number of CDK2 inhibitors also now coming in clinical trials. Again, a number of trials now looking at combinations. Ivosidenib combining with nivolumab, another anti-PD-1 agent, DS1001, I talked about there. New agents which are coming, which are targeting both 1 and 2, and then looking at vaccine plus other approaches, combining them with temozolomide. So really a smattering of trial opportunities for our patients, which is really great for us who are physician scientists. Obviously, as we were discussing, can Vora be used in higher grade tumors like grade 3 and 4 IDH mutant gliomas? We get calls about this all the time, and also our patients ask them. So there is actually evidence in a presentation which will be on Sunday at the 11 to 12 p.m. So please go there. The key takeaway is that vorasidenib at least was well tolerated in a heavily pretreated population with 3 to 4 IDH mutant gliomas, with low-grade transaminitis and fatigue. These are the most common toxicity. And the preliminary evidence is showing that at least in more than half of our patients, we are getting around 3 to 4 months. That is obviously not the kind of data we have seen for grade 2, but we also know that these are heavily pretreated patients. And for them, getting stability of the tumor at least is more time with a good quality of life. And then we also have had off-label use of vorasidenib from a single institution, and this presentation is available on Saturday. And again, similar story, signs of clinical benefit, but well-tolerated drug, and that we have a ton of data for that. So this is case 2. Now we have a 22-year-old female patient who has an IDH2 mutated grade 2 astrocytoma, had prior surgery, now is requiring systemic therapy to manage disease. Baseline testing confirms adequate hepatic and renal function. What are the treatment options you would consider for these patients? Clinical trials, as Dr. Cloughesy included, is always an option for our patients and is preferred option in addition to standard of care. Obviously, we have to look at the AE management, and if we put on the vorasidenib, what are the safety assessments that need to be conducted and how often, and as he basically alluded to, what he does in his practice and we all do. So please feel free to take a moment to answer the follow-up poll on your understanding of the novel therapies for IDH mutant gliomas. So some of the summary and the key takeaways, I hope we were able to impress on you that IDH inhibitors, vorasidenib, ivosidenib, have demonstrated efficacy for benefit for patients with IDH mutant gliomas. There is emerging data from ongoing clinical trials with a number of agents which will inform future directions for monotherapy or combination approaches and sequencing strategies even. Education is critical for patients and care partners. It takes a village to take care of a brain tumor patient, and I cannot thank enough our advocacy partners like ABTA, who help us take care of our patients and helping them live a better quality and better, more functional life. Obviously, the current management of IDH1/2 mutated gliomas is associated with substantial physical, emotional, and socioeconomic impact, and the previous treatments did not address QL issues enough, but now we saw obviously some beautiful data helping even with seizure control with vorasidenib. Patient experience requires improvement to maintain quality of life, while controlling disease progression and long-term survivorship becomes even more meaningful through preservation of functioning and well-being. And Kevin shared with us his beautiful story of how he has been able to do that with vorasidenib participating in the trial. So right now, we would obviously love to open this for polling. So please use the QR code, submit your questions, and Dr. Cloughesy and I will go through these. So I'm going to start off with first one, and obviously asking Tim, obviously he's been a thought leader in the field. What are some of the important biomarkers that are available for targeting glioma treatment? Or when you have a patient with glioma, what are the important markers you're looking for, which are informing treatments, as we discussed, but also the important ones which will be important in designing the next cadre of clinical trials?
Yeah, I think there's two things that help us understand whether we should be checking for a biomarker. The first thing is it provide some prognostic understanding? Does it provide a unique disease-defining setting? So for those, we definitely want to make sure we get those biomarkers, their IDH, and so that will help us understand if they're IDH mutant or not. If they're IDH wild type, the other biomarkers that at least at a minimum are important are going to be whether EGFR is amplified or at least there's polysomy, whether you have monosomy 10, a TERT promoter mutation. Those kind of help us whether histopathologically lower grade or even in the setting where it's histopathologically has higher grade features, that helps us kind of narrow down is that a glioblastoma. Then with the other targeted therapies that have been approved, there's a real interest in the BRAF fusions, BRAF V600E, as well as the H3K27M. So those are more driven by therapies that could be associated with them. Certainly, if there was a BRAF mutation and it was in a pilocytic astrocytoma setting without the ability to use a drug like tovorafenib, I'm not sure everybody would need to get it, or the combination of the MEK and BRAF inhibitors. If that data wasn't available, there probably wouldn't be any reason to get it. So the same thing for NTRK fusions, I think, are something that we can define as a population of patients where an NTRK inhibitor would make sense. So again, you have your prognostic kind of disease-defining set of mutations, and then you have the therapeutic mutations. We like MGMT, even though we have separated out in glioblastoma, and I think it helps us with regard to trials. It's not that we treat the patients differently. Maybe we have different anticipation about pseudoprogression, these types of things. So maybe it helps guide a little bit of clinical therapy. But in general, I think it also, and it provides prognostic information to the patient, so that's always nice and helpful. I'm sure I'm missing some others that you could think of that we
No,
should
you
throw
really
in.
very eloquently covered it, and I think the key take-home message is please profile your patients.
Yeah.
Because, as you alluded to, NTRK is a tumor-agnostic approval, right? So it's the good part is that we can use that, and there's a 1% alteration in glioblastoma, but there's a much higher 8 to 13% alteration in pilocytic astrocytomas. So I think when you look for these things, you find it. And then obviously as we treat these patients, the surgical trials look at, more important, the biomarkers of resistance, which helps us define better combinatorial trials, which actually leads into the next question, which was basically monotherapy versus combinatorial therapy. And I think that's where the field is now moving, right? In the patients who have pure IDH alterations, we know we were able to show you that the IDH inhibitors are working well. But then if people have CDK2 loss, we know those will not do well with just IDH alteration, but that's where I think combining with the CDK4/6 inhibitors and showcasing the safety of those combinations, but also the benefit is going to be where the field is moving. It'll be exciting to see in combination trials the benefit of using vorasidenib and then using an anti-PD-1 blockade, because the mechanistic data, and I think that's the beauty of doing these mechanistic studies, is you are actually informing how logically and biologically rational way to add therapies to that. Because a lot of times when you're not very well informed, we have used a combo which only adds toxicity and
Yeah.
sometimes doesn't help benefit. So I think really it will be intriguing to see what those combos
Yeah,
show.
I think it's interesting that you say that because I think people underestimate the value of these tissue-based studies and how they give us insight into what's going on. Obviously, there's a very strong epigenetic component to the process of formation of these tumors through 2-hydroxyglutarate. So it always, like demethylation makes a lot of sense too, right? Like in combining those and changing the gene expression profiles of these tumors to hopefully create a susceptibility that leads to some of this. One of the other things that we didn't cover that I feel like it's an ongoing discussion, which is what's high risk, what isn't
Oh, yeah.
high risk? For those of you who remember the Pignati criteria, there's a variety of different things in there, but age was a really important one. And one of the things that I pointed out in the forest plots was that the older group actually seemed to do better with regard to hazard ratios in terms of the treatment effect. And we also did some other evaluations having to do with tumor growth rates. It didn't really seem to be like the older patients really had faster tumor growth rates. In the end, and I'm sure you have these, have some patients in their 60s, even in their 80s, who have an IDH mutant glioma. And we still feel they probably formed early on, that they probably formed during this teen to early 20s, that is during the time of methylation of the temporal lobe, or myelination of the temporal lobes and the frontal lobes. And it probably took that long for it to show up, which means it's probably pretty slow growing. And we always look at, well, what's the survival of somebody who's 80? Well, the survival's shorter because they die of other reasons. And it doesn't necessarily mean it's a more aggressive tumor. And so I think that's always something to consider. But what are the things from your point of view that, if you see certain features, maybe on histopathology, maybe some other molecular features, that maybe pushes you more toward, gosh, I think we really should be doing radiation chemotherapy? And I really don't know the answer. I mean, I have some
Yeah.
things that I would guess about, but.
Yeah, I think that's the burning question facing all of us, right? And I think a lot of times we use our colleagues from radiation also to chime in. And I think when the initial trial came, frankly, there was some apprehension
Yeah.
with the radiation colleagues were we not providing a treatment that has shown a survival benefit. And I think what was really very invigorating for me was to see some of the mechanistic data and the kinetics data, because frankly, I was as well, because obviously there were some questions about the trial design. And we saw the differences in the placebo arm that you compared. But as we have generated more data, what we are seeing is the kinetic change really of these patients who had a curve that was going up,
Right.
and then we see nice downslope.
Yes.
Right? And then as we get more and more data, and obviously you have the Lancet paper update now, showcasing that actually as it's maturing, the difference is actually getting bigger, which is
Right.
even nice and reassuring.
Yes.
And second is what some people were worried about was that relative pressure. Are we putting pressure, and then is the tumor going to be much more aggressive? Now, obviously, we
Right.
still need a longer follow-up, but that's another apprehension. But I think overall, what we have seen is that there was a mechanistic rationale. Congratulations for being involved and leading several of these trials, the surgical studies in particular.
Yeah.
And I think that has helped me and a lot of other colleagues now who are more open to at least considering these alterations and putting these patients on. And I think it's going to be a moving target.
Yeah.
And I think we will be more and more comfortable as we get more and more data, and as that can be ensured. And meanwhile, we are getting also off-label use that is informing some real-world evidence. But I think I wish I could say what a clear thing would be.
Right.
But obviously, if we have aggressive features or things that we believe will be more aggressive, then maybe radiation and chemo is still an option for those patients.
Yeah.
But there are a lot of patients who we would say, well, I want to treat this, but the patient doesn't want this. And a lot of patients
Right.
want to avoid radiation
Right.
because they know the neurocognitive
Yes.
side effects. So,
Yeah.
in fact, I have a lot of patients now saying, no, I want to do this.
Right.
And I'm going to keep that in the back burner if
Yeah.
I need to use it later on. But as we get more and more data, I think we'll have better informed discussions with the patients.
Yeah, I was trying to think about what we learned in the trial, one of the things we learned in the trial that we presented, but it wasn't really highlighted, was that those that have faster growing tumors at baseline have a shorter progression-free survival, but their effect size is still the same. So compared to the group that's growing slower, well, that makes sense. I mean, but nevertheless, it's probably pointing toward, it's picking up steam, it is more aggressive. So to correlate with that, maybe it is like a high Ki-67, something like that, that might be associated with kind of more rapid cell division. Or I'm really fascinated by this idea that when we do our DNA copy number analysis, and at the same time we do a FISH analysis of CDKN2A, that many times we'll see 3% homozygous CDKN, with FISH, and it doesn't get picked up at all on the DNA copy number. But I don't know what that means. But then you also have this heterozygous group as well. And that really, when you begin to have higher percentage of the cells having a heterozygous loss of CDKN2A, that may be something that is pushing us in that direction. We've seen already that the survival looks like it's different with that population. So maybe it is implying that they are beginning to divide faster. They may be a group that would maybe think about doing radiation first. That doesn't mean they couldn't later use vorasidenib if those studies turn out to be positive that you showed, but that may be something that kind of gives us some insight into what these groups are. Go please.
No, it's flashing that we are out of time now. So what I would love to summarize is, I think that what makes our work exciting.
Right.
We get up every morning because we do know that disease biology dictates the outcomes. But whatever difference we can make in lives of our patients is so invigorating. But also it inspires us to work harder. And I remember one of my first discussions with you was always think outside the box. Right. I still remember we had this discussion, almost 15 years back when I started. But I want to take this moment to thank all of you for spending your time with Dr. Cloughesy and me today evening. I hope you were able to learn some things. We definitely want you to profile your patients. And obviously, some take-home messages are, please complete and submit your post-test and evaluation for credit. Please feel free to download the slides and practice aids. I see there are several fellows in the room. Stay tuned for the online activity based on this event. And again, thank you so much for joining us. It takes a village to take care of our patients, but I could not be more exhilarated about the future for our patients. What I want you to take home is hope. And as we are doing more of these trials, we are learning more. And as Dr. Cloughesy alluded to, we are getting smarter. And that's the whole point. Can we get smarter and make decisions for patients one at a time? Use the evidence we have to make the best decision for the patient we see. Thank you so much and have a great evening.
Thank you.